Management preoperatively emergency using an A, B, C, D, D, D type of arrangement. Ladies and gentlemen, welcome to my YouTube channel. Yet again another episode. Let us now learn how to manage shock. So in today's video, we're going to be talking about management of shock. Yes, management of shock. Let's begin. So with me here is a question, and the question reads: Mrs. Rita Shakespeare, a 40-year-old human resource officer from a certain company in Livingston, is admitted to your ward with a diagnosis of traumatic amputation. Alright, traumatic amputation. And this amputation is of the left arm, and this happened during a fight with strangers at her farm. She is in shock and scheduled to go for a fashioning of the stump in theatre. Question number 1. Define psychic shock. Question number 2. State any 5 signs and symptoms of shock. Question number C. Describe the preoperative management you will give to her. That's 50%. And lastly, describe the complications, 6 of them, that she may develop post-operatively. Let's quickly dive into it. Question number 1. Let's respond. So how do you define shock? You can define shock in the following way. Shock is a physiological state in which there is inadequate blood flow to the tissue and cells of the body, causing inadequate organ and tissue perfusion, which later results in derangement of cellular function. That's how you define shock. Quickly, how do you define vasovagal shock or psychic shock? You define it in the following way. This is a type of shock that results from extreme and excruciating pain or fear, in brackets anxiety, and it occurs immediately as a result of fright, for example, receiving bad news or sudden severe pain to a sensitive part. With you defining it like that, you already have 5 marks waiting for you. Just don't forget to add a heading there like I have done. You can write your heading of the term that you're defining, underline it nicely, and quickly outline your definition. Let's proceed. What are the signs and symptoms of shock? Sign and symptom number 1, pallor. So this results from the loss of effective circulating blood volume, which initiates a metabolic and physiological reaction that leads to poor perfusion and hence the pallor that you're going to see. Pallor can also be defined as the unnatural grayish discoloration of the skin, which is secondary to tissue hypoxia. Right? What is our second sign and symptom? Heart rate accelerates. While the systolic blood pressure lessens, which is also known as hypotension, due to reduced coronary perfusion, there's going to be accelerated heart rate. Number 3, weak, thready pulse. A patient who's in shock is going to have a weak, thready pulse. So this results from the loss of effective circulating blood volume, which is going to result into a pulse that is weak and thready. We proceed. The 4th sign and symptom is hyperventilation. So this is caused by stress leading to alkalosis, which follows acidosis, and this makes the patient hunger for air and therefore hyperventilates. Alkalosis is simply a state in which the alkalinity of blood increases, which also comes as a result of acidosis, where the acidity of blood increases. So this makes the patient hunger for air and hyperventilates. Lastly, lip cyanosis. So due to reduced salivary secretion and dry mouth or oral mucosal membranes, followed due to peripheral vasoconstriction, causing less blood flow. So due to reduced salivary secretions and dry mucosal membranes, the lips become cyanosed, and by that they appear to be bluish, grayish, bluish. Ladies and gentlemen, those were the signs and symptoms. Now let's get to the big piece of cake, which is the management. How do you manage a patient in shock? This is an emergency, ladies and gentlemen, and we're going to resuscitate using a method called A, B, C, D, D, and D. Quickly dive into it. What does the A stand for? The A stands for airway. So you can write airway, underline it like I have done, and you can explain the following points. Number 1, I will inspect the airway for obstruction by secretions and suction them accordingly using a working suctioning machine. That's nice. Number 2, I will observe for paradoxical chest movements and use of accessory muscles for breathing. So If so, I will reposition the patient in semi-phallus position to maximize lung expansion. Number 3, I will inspect for tracheal deviation, noisy air entry or exit, and cyanosis, and if so, I will nurse the patient in semi-prone with head tilted and neck extended to allow drainage of secretions. So when you're writing these points, you explain what you're inspecting or what you're assessing for, and if there's a problem, you intervene like I have done. Let's quickly move to the last one. And if completely obstructed, I will intubate the patient to promote airway patency. Ladies and gentlemen, that's it under airway. We quickly move to breathing. You write your heading breathing and you underline it like that. So what do you explain here? I will assess the patient's respiratory rate to find out if the patient is making normal respiratory rates or efforts. With that written, ladies and gentlemen, I will count the patient's breath rate if falling between 12 and 20 breaths per minute. If below, the patient has got bradypnea, and if above, the patient has got tachypnea. So ladies and gentlemen, we proceed. I will assess for the respiratory distress, such as use of accessory muscles for breathing or abdominal muscles for breathing, and lastly, sweating and cyanosis. When you assess for these, ladies and gentlemen, then I will commence humidified oxygen by mask or by nasal catheter so that you can improve tissue perfusion. And lastly, if the patient is still having difficulties in breathing, I will put on respiratory support such as a ventilator. So these ventilators can either be CPAP or IPPV. CPAP standing for continuous positive airway pressure, and IPPV standing for intermediate positive airway pressure ventilation. Ladies and gentlemen, we quickly rush to the circulation. You write your heading nicely like that and you explain the following points. Number 1, I will assess the capillary refill time to ascertain euvolemia or hypovolemia. Euvolemia means the blood volume is normal and hypovolemia means blood volume is low. So you assess for that. Number 2, I will assess circulation by palpation of radial artery for pulse rate to note any cardiovascular dysfunction such as tachycardia or bradycardia. With that, ladies and gentlemen, thirdly, you can say, I will establish an IV access using a sterile cannula for fluid administration, specifically 18G or 16G, because this is an emergency. So you want to administer your fluids at a very fast rate, at least 60 drops per minute. And lastly, I will commence plasma expander such as normal saline 1 liter to run at 60 drops per minute in the first 30 minutes. And then you can also add to it to say, I will administer an extra liter to run at 40 drops per minute in the next 4 hours. With that said, ladies and gentlemen, we quickly rush to D, which is standing for degree of consciousness. Now this sounds new, but it is very much necessary. So what do you explain here? I will assess the patient's level of consciousness and level of orientation. That's number 1. Number 2, I will assess the motor reflexes to note level of consciousness. Number 3, I will assess the patient's verbal response to note if coherent or incoherent. Number 4, using a Glasgow-Coma scale, I will grade the patient accordingly, and if the score is less than 7, I will refer to intensive care unit for specialized care. Ladies and gentlemen, we proceed and we go to deformities. What about these deformities? So number 1, you explain, I will inspect for presence of fractures of the spine, and if not, I'll confirm, I will inspect the presence of fractures of the spine, and if not confirmed, I will move the patient as if has spinal injuries. That's number 1. Number 2, I will inspect for fractures to the head to note presence of head injury. That's a nice point. Number 3, I will assess the patient's upper and lower limbs for any injuries, which in this case, the upper left arm or limb is deformed. Therefore, I will splint and immobilize. With that said, ladies and gentlemen, we can go to our last D, standing for drugs. And under drugs, we're going to assess the level of pain to note if the pain is severe. And if the pain is severe, you're going to administer a strong analgesia to relieve pain. An example of this analgesia is pethidine, and the dose is 50 milligrams. Ladies and gentlemen, having resuscitated our patient, let's go to secondary assessment and care. In our subsequent care, This patient is supposed to go for theater or an operation. And because we have resuscitated our patient, we need to give our patient an environment. Let us start. What do you explain under environment? So I quickly outlined bulletins so that you can write your sentences nicely, making this easy and quick. Number one, you mentioned the ward of admission. The ward of admission is a surgical ward. You mentioned the area of admission, acute bay. You go to your lighting and ventilation. You explain that you will provide adequate lighting and ventilation. You explain about the cleanliness and noise-free of the environment to allow rest and to prevent infections. Equipment and bed accessories. You explain you're going to immobilize a cylinder for oxygen administration, a drip stand for fluid administration, and the rest of the things such as a TPR tray, everything that you can immobilize near the patient's bed. Also, positioning. What do you talk about under positioning? Talk about the position itself, which is semi-recumbent or semi-prone, followed by 2 hourly turning. Alright? Then you talk about a turning chart, and then you talk about jelly and powder whenever you turn, because you're going to be doing pressure area care. With that, ladies and gentlemen, you talk about other equipment and bed accessories such as air rings. You also talk about a backrest. All that is supposed to help you reposition your patient. And also, cardinal control tests. So to easily write your preoperative management, which is an emergency, you can write the headings down, then you can write the first letters of each heading and make a mnemonic to follow in that order. Cardinal control tests. What do you write there? Number one, you mentioned I will collect blood for hemoglobin estimation. Number two, I will collect blood for urea and electrolyte checking. You also talk about blood for bleeding and clotting time, because this patient is going for an operation. So the surgeons must know if the patient has got any bleeding tendencies such as hypofibrinogenemia. Alright. Then lastly, you talk about blood for grouping and cross-matching. Then you go to psychological care. What you explain there? Firstly, I will explain the condition to the patient to understand, to allay anxiety, and also to promote knowledge. Number two, allow the patient to ask questions based on the condition. Number three, explain procedures and get permission to allay anxiety. Number four, I will reinforce the physician's advice and answer questions accordingly. And lastly, explain about the surgery to allay anxiety. Tell the patient what to expect in theater and what's going to happen after the operation. With that, ladies and gentlemen, we go to our next section and we're going to continue with consent form signing. So what do you write here? I will explain reasons for getting consent. Number two, I will explain the importance of a consent form. Number three, I will make the patient sign the consent form. Number four, you're going to involve a witness whilst the patient is signing. Then we go to nutrition or fluids administration, which is going to include nasogastric tube feeding and nasogastric tube insertion. Let me not spill the beans. Quickly, keep the patient new orally. Keep the patient new orally. Why? Because the patient might aspirate during surgery. Number two, insert a nasogastric tube. This nasogastric tube is supposed to be a lavage if the patient had anything in the last 6 hours, and also for feeding when the patient comes back from theater in case the patient fails to tolerate meals orally. And also talk about a gastric lavage, as I mentioned earlier, if the patient took meals before or within before the end of 6 hours. Yes. Then talk about intravenous for feeding. Intravenous fluids, these include a normal saline itself, meaning the patient should not take water, not take anything by mouth. They're going to give the water via IV, that is Ringer's lactate and normal saline. And you're also going to feed with glucose. You're going to give dextrose, which can be 10 or 5%. Then we proceed. What else do you talk about? Immediate observations. Having positioned, having talked about the nutrition, having given psychological care, what about the immediate observations? So firstly, they're going to observe the airway, breathing, circulation, and degree of consciousness as usual. Then you're going to talk about temperature, pulse, and respiration. Temperature to not rise or fall, which can be indicative of any problem, infection or hypovolemia. And then pulse is going to indicate tachycardia or bradycardia. Respiratory is also going to indicate above normal or below normal. Having talked about that, ladies and gentlemen, talk about blood pressure. The blood pressure is supposed to tell you whether the patient is in hypotension because the patient has bled, or the patient is in hypertension, which can be secondary to fluid administration. Ladies and gentlemen, we proceed. You talk about the urinary output. You do not want to overload the patient, and you also want to ascertain renal functioning. Having looked at that, you talk about patency of catheter. You have already catheterized your patient, so you're going to observe if whether or not the catheter is patent and if the catheter is working perfectly. Having looked at that, we quickly go to physical preparations. I will slow down here. What about physical preparations? Number 1, cannulate the patient. For administration of drugs in theater using an 18G cannula with a green cup. Number 2, catheterize your patient. Alright. Number 3, shave your patient from nipple line up to mid-thigh. From nipple line up to mid-thigh, as well as shaving the area to be operated on to reduce on microbes. And also remove any jewelry. Alright. Remove any jewelry or dentures. When you remove jewelry or dentures, you're going to prevent electrocution in case of use of a diathermy machine. And then insert a nasogastric tube, which is supposed to be used for feeding and gastric evacuation. And lastly, label your patient, including the name, the age, the sex, and the type of surgery the patient is going to go for. And lastly, gowning the patient. You're going to put a gown on the patient and get the patient ready for theater. Having done that, ladies and gentlemen, what is next? Premedication. So having prepared our patient physically, we're now going to give medications prior to surgery. Medications, for example, atropine sulfate 0.6 milligrams intravenously. This atropine sulfate is supposed to help dry secretions during the operations. And then you can give antibiotics for prophylaxis such as metronidazole 400 milligrams intravenously for prophylaxis. And then you can make the patient sign the consent form. Alright? Make the patient sign the consent form. Having done that, ladies and gentlemen, we talk about handover to theater nurse. What about it? You are going to transfer the patient to theater, and when you transfer the patient to theater, you're going to explain the following points before giving handover. Number 1, I will walk by the head side of the patient, giving continuous reassurance and observing. And the porter will walk by the foot end of the patient, pulling the trolley, leading way to theater. Alright, then you mentioned the following. During handover of the patient, I will give handover to the theater nurse about the patient's name, the age, the sex, the latest vital signs, latest preparations, and everything. And then I would tell him about the name, obviously, as I have explained, the diagnosis of the patient and the procedure the patient is going for, and then the physical preparations that have been done, in a nutshell. We proceed. Having given handover, ladies and gentlemen, you're supposed to return and attend to family needs, because the patient's family will be in suspense, with anxiety and full of questions. So you will tell the relatives that you have left the patient in safe hands of competent health team in theater. If possible, I will also confirm to them the progress of the operation to keep them updated. Like that, it means you're going to attend to family needs and you're going to gain yourself some extra marks. And then lastly, preparation of a post-operative bed. You now have to prepare a bed where your patient is going to lay after the surgery. What are some of the things you immobilize there? Number 1, you make a post-op bed accordingly. Number 2, a SFIG for blood pressure checkup, a stethoscope for auscultating heart rate, pulse rate, and arrhythmias, and then a thermometer for temperature, MSS ball in case the patient feels like vomiting, recording charts to record all latest vitals, preparations and procedures done, a drip stand for fluid administration, a working suctioning apparatus, an emergency tray, yes, a sterile syringe, needles, and a tourniquet. Our emergency tray is going to contain emergency drugs and the like. And lastly, talk about a post-operative tray. So a post-operative tray containing a mouth guard, an MSS bowl, tongue forceps and a spatula and the like. Ladies and gentlemen, this marks the end of the management. So you've resuscitated and you've managed your patient, you've taken to theater. What are the complications that the lady might develop post-operatively? The first one is hemorrhage. This is escape of blood from a ruptured blood vessel. So this hemorrhage can occur if a blood vessel on the stump dislodges, leading to escape of blood and bleeding. With that said, we go to wound infection. So wound infection may occur if there's any break in sterility of the wound during cleaning and if the patient touches it, or introduction of microbes to the area. Number 3, dehiscence. So to dehisce simply means sutured edges separate. This is due to accumulated pressure, which may be either secondary to hemorrhage or pressure exerted on the wound. Also, chronic inflammation. So a chronic inflammation may occur if the inflammation is prolonged. This can be either due to a presence of infection on the site of surgery and the like. And the other one is depression. So because this lady has lost her arm, it's been amputated, she's worried. How would the society perceive her? If she's a human resource manager, if she was left-handed, she's going to be depressed because she feels her job has been compromised, all right? Then lastly, hematoma. So a hematoma is simply accumulation of blood underneath the layers of the skin. So when there's accumulation of blood underneath the layers of the skin on the site of the surgery, there's going to be accumulation causing pressure, causing pain, and this may lead to clotting, and that may disturb the healing process. Ladies and gentlemen, these are the complications. So we have defined shock, we've stated the signs and symptoms, we've looked at the emergency management, we've prepared our patient for an operation, and lastly, we've looked at the complications. Having said that, ladies and gentlemen, this marks the end of our presentation. Thank you very much for watching. Don't forget to subscribe to my channel, because as you subscribe, you're gonna get more videos. Don't forget to hit the notification bell so that whenever a video is on my channel, you get updated. Ladies and gentlemen, this marks the end of our video. Thanks for watching and have a lovely day.